Hi, good evening, everyone, and welcome to this section. Our time is spent on the technical issues that we have. Would you mind if I start now?
Yes, please.
Yeah.
Prof, good evening, sir.
Good evening. Yes, good evening, sir. I can start now.
All right.
Good evening, Prof.
Yeah, good evening. How are you?
Good evening, Prof.
Good
Good
evening.
evening.
Yes, welcome, sir. Good to have you.
Yeah, thank you very much. So if you go through the schedule, you'll see that today I should be talking about healthcare financing or health system financing, and then looking at health system models and typologies, which we're looking at assessing health system. Basically, I will try to do this before the time, or possibly just take a little bit of your time. All right, so I'll start with financing, and then we go to the comparison health system. Okay, so when we talk about the function of health system, we spoke of 4 functions, and in the area of the pillars, we talked about 6 pillars, which are actually structural pillars, for the health system. And financing is one of them, or one of both. So healthcare financing is a very important concept, and it's important to understand because many things you want to do in systems like healthcare, you need to understand the financing mechanism and be able to play around. So when we talk about financing in healthcare, can we mute our system, please, if you don't mind? Kindly mute your system. Yeah, so we don't have distraction. When we talk about financing, we're looking at how money is mobilized, how it is pooled, and how strategic purchasing is undertaken, in healthcare. We're looking at the efficient way of managing the resources available to healthcare. And the purpose of financing is to ensure that there is access to healthcare. And to achieve that, you need to optimize the resources so that it can go for more people, gaining benefit from that financing. That's under the principle of utilitarianism. We also see that it's to promote equity in healthcare, ensuring that everyone has access to healthcare, irrespective of their financial standing. And so in that sense, wealth is not seen as an advantage, and poverty shouldn't be a disability when it comes to accessing healthcare. We also see that financing helps us to protect households from financial hardship. And this is where we see the burden of healthcare cost. When you have people with some kind of health conditions, such as long-term conditions, either single or multi-morbidity, or conditions that require operative care, which we know are very expensive. Financing also helps us to improve health system performance through the efficient use, of resources. So kind of why we've argued earlier on that governance is core in what we're doing, there must be financing for any health action, to be undertaken. So financing is equally important. And the core element in financing is revenue collection. How are they collected? You understand? Most times you see that there's really no collection mechanism. People just pay at the point of access to healthcare, which is called a cash and carry system or out-of-pocket payment. In most other systems, you see that either taxes are collected efficiently by government and used to provide healthcare, or people subscribe to either private or social health insurance, and through that subscription, they are able to. So financing looks at collection, the risk pooling. How do we spread risk across a large population? The last time we met, I spoke to you about the issue of cross-subsidization, where the healthy rich subsidizes or subsidize the sickly poor. So this is about spreading risk and also prevent individuals from bearing the full cost of healthcare, as we see in the social health insurance system. And then the last function of financing is purchasing, strategic purchasing. We all understand the economy of scale, which means that with bulk buying, you are able to achieve or to leverage and get the pricing right. So when a system like the National Health Insurance Agency Authority or the State Health Insurance Agency, negotiate cost on the basis of bulk buying, it kind of reduces the per unit cost, for accessing healthcare. So the functions of health insurance is revenue collection, risk pooling, and strategic purchasing. Strategic purchasing. And the reason why we do this is we're going to discuss around this. We see health as a product most of the time, but we see the health market is not a perfect market. And that is because there are a lot of market failures, when it comes to health. So we'll take time to look at some of these issues around the unpredictability of the health market, the unpredictability of the health market. The first has to do with the demand for health. There is a fairly inelastic demand for health, inelastic in the sense that even if the price goes up, to a large extent, people will still make demand for health because they need it. They need it for their survival, so they must go for it. Recently, there were issues around the dollar naira discrepancies, and that led to the cost of medicines skyrocketing. Medicines like anti-diabetic medicine, antihypertensive medicine went very, very high. And in that instance, what happened was that people will still have to buy. They will do all kinds of adjustments, including, cutting off some legitimate expenses so that they can be. So we say that health is fairly inelastic. And also the demand for health is unpredictable. Unpredictable demand is in the sense that no one knows when the demand will come. You may just think, oh, everything is well, and then you find out that there's a departure from good health, and you now need to. So you cannot predict, you cannot put it on a balance of probability that, oh, you'll be healthy for the next 1 week or for the next 1 month. So we see that unpredictable demand and also the inelastic demand. Is that clear to everyone? I'm trying to explain certain things which will be relevant to you.
Yes. Yes, Prof.
Okay. Exactly, because during emergency, someone just told me today, she's in the US, and then the husband, the daughter, who she went to see, had an emergency. She's heavily pregnant anyway, and so one would think that pregnancy is a physiologic process, but anything, the tide could turn at any point in time. We also see cases of accident, which are not planned, but they happen, and we need to seek healthcare as much as possible, so it's important we understand that. Then we talk about the asymmetric information. Asymmetric information. Now, what that means is that if you are dealing with a perfect market, you, the buyer and the seller, may have fairly good knowledge about the product you are looking at. For example, you want to buy an iPhone. Many of you would have studied it. You see all details of iPhone, all the features and so on. So if you go to the shop, you are rather going to test this iPhone you're saying to make sure that it has all these features. But when it comes to healthcare, there's asymmetric information. The seller has more information than the buyer. So that skewed information asymmetry, can cause a problem. You understand? Because if the seller knows more, he could use that to his own advantage. We've seen situations where, although this becomes moral hazard, where our suppliers induce demand, where because of skewed information, suppliers begin to induce some demand. You see a patient with uncomplicated malaria, which should just be treated, on an ambulatory basis and sent home. And then you prescribe that the person stays in the ward, at least for observation for a night. By staying in the ward, he's going to pay more money. You understand? And because the patient trusts his or her doctor, it's okay, doctor said you stay, so let me stay. But the stay is actually not because there was a clear indication of staying, but because the seller wants to utilize his resources and get more money, from the patient. So these are supplier-induced demand. At other times, you will see that there could be the buyer requesting for certain things that are not really necessary. We call that moral hazard. Somebody has subscribed to an insurance, has not fallen ill over time. He feels cheated. He said, well, why am I paying every month? It's so huge amount and I'm not benefiting. And then goes and says, yeah, supplier, you must give me this. And supplier said, no, but there's no indication for that. So if you don't do it, I will stop my enrollment with your facility, because I need this, I've not had it. Or maybe the buyer may even find some symptoms. Oh, I'm having pain here. Oh, it's paining me as they touch. I start reacting. And the supplier said, well, pain is subjective in a way, so it prescribes the kind of analgesic he's looking for, and he takes it home and says, well, I've gotten something from the system. So these are things we see in the health commodity market. You understand? And then it's also important, I stress at this point, the fact that as suppliers, we are agents, and then the buyer, the patient, is the principal. So if we go by the agency theory, we know that we are supposed to use our knowledge, to enhance or enrich the patient so that any patient that comes to us as providers will be empowered. Now, empowerment means that the patient has got enough knowledge, has got the skills to be able to take care of his or her condition. So we don't blindfold patients in a way that they must stick to us at every point in time, but we empower them because it's been observed from studies, especially as we transit from acute to long-term illness, that those who do well, as sufferers of long-term health conditions are those who are empowered. And by that, I mean those who understand the disease conditions, they know what to do. In fact, they become their own doctor in any case, because they know exactly what to do. So that's very important to note. Also in healthcare, it's an uncertain outcome. No one can guarantee the results. First of all, you may come to a hospital with a case of headache and feel like if I go there, they give me analgesic and that will be true. They went and they searched and they saw that headache was caused by, a poor that is a refractive error. Uncorrected refractive error means that you have a bad sight and you didn't know. And so with that, you began to do refractometry, you began to do check the pressure in the eye, and then you now go on to do refraction, and all that goes on. You didn't know, you did never budgeted for it. But you thank God and say, well, after all, they've been able to find that. In other sense, you see that a simple headache can lead to a diagnosis of a space-occupying lesion, because the way the headache has come, which looks so innocent or insidious, and then you go in, and then the scan is done, they see something there. Oh, you need to do a brain surgery. There's uncertain outcome. Hello? There are also instances where people have gone for their annual medical checks and they were given clean bill of health, and then they return back only to die. You understand? The question is that what went wrong? Everything has been done. The parameters shows everything is right. The doctors confirmed that, and then death came knocking. So health has a lot of uncertain outcome, no guarantee results from any treatment. And so we also see the ethical concern that health is not just a right, it's a right and not just a service. So there is the patient bill of right. And if you go to the Constitution, you see the fundamental human right, but when you go to our ethics book, we have the Patient Bill of Rights. So patients have certain rights. It's not a favor being given to them. It's not service, but a right. And then the issue of externality comes in. Externality. But before I talk about externality, we need to look at the issue of consumption when it comes to health. There is a dual nature of consumption and investment. We see health as a consumption good, meaning that you need health to live. You need health to improve your quality of life and your well-being. But we also see it as an investment good. As an investment good, we knew that to be productive economically, you need to be healthy. To be able to read, learn, and improve yourself, you need to be healthy. So health becomes an investment good in this and not just something we need, just for having a quality of life. So we see healthier people more likely to be economically productive and contribute more to the society, So talk about the externalities. Externalities are real in healthcare, and you could have it as a positive externality. A positive externality is the fact that by mere taking caution and isolating myself, if I have a health condition, I am protecting others. The same way when I subject myself to vaccine, in the case of an epidemic, I'm contributing to the herd immunity that will give everyone, a kind of protection, you understand, in the community. And so we see certain aspects of health services considered as public good. No one should be excluded, and nothing should compete with that. And one of it is the issue of sanitation. Everyone needs good sanitation. Everyone needs to have immunization. In fact, most of the preventative services, are expected to be available to all right? We also see health as a case of basic human rights. Human rights, I've emphasized that before. And then we see government getting involved in health. Now, market alone cannot ensure fair access to health. In many sectors, we say let market rule. We can see what is happening to the downstream petroleum sector for those of you in Nigeria. We've had it rough and turbulent. But since Dangote came into the market, it has stabilized the market. As a matter of fact, it has brought healthy competition. You understand? Even if there are government factors that are trying to frustrate local production, or at least not supporting local production, we've seen that the bull approach by the entrepreneur, seem to outweigh whatever the government may be trying to achieve through their action. And so, but when it comes to healthcare, we can't leave it in the hands of the private. The reason why the American health system is the most expensive, but not the most efficient globally, is because it's left in the hands of private. So private health systems are rather expensive, and they do not guarantee, coverage for all. As a matter of fact, private health insurance have a lot of setbacks, because even for the rich, you are only attracted to by them, or you are attracted by them once they see that you have the money to pay and you don't have the risk to claim. So once you meet those conditions for people who are business driven, then that works. So, but government must, in fact, government role is to ensure that one, they regulate healthcare. Two, they create enabling environment for all actors to thrive when it comes to healthcare. So health services are heavily regulated or publicly provided. We have considered a couple of options, which I believe if you have time, you can have discourse around it. We look at the two sides of the divide. One is the financing of healthcare, the other is the provision of healthcare. So looking at scenarios like this, a publicly financed, a publicly provided, that's a dyad. A publicly financed, a privately provided, that's another dyad. A privately financed, publicly provided, that's another dyad. And then a privately financed, privately provided. Which of these dyads do you think can guarantee greater efficiency, access, and quality health service? Yes, I want hands raised at this point. I've created 4 dyads. Yeah, where are my smart colleagues here? Oluchi.
Good evening, Prof.
Good evening.
Okay, I will go for publicly financed and publicly provided.
Why?
Okay, like you explained, if the government, that's publicly means if the government can finance healthcare and also equip all the federal teaching hospital, the general hospital, primary healthcare. I think in the case of healthcare, there will be equity and social justice. Like everybody, both the rich and the poor, will be able to access healthcare, especially in Nigeria.
But if you look at the state of public service provision, not just healthcare, what will you speak Nigerian public service?
Okay, public service.
In Nigeria.
Well, it's not the issue about public service in Nigeria is because they are not properly managed.
So do you think health will be different? Or do you think health is different?
I think in a greater sense, health will be different than other sector.
Okay.
From my own thought.
No, you see, health is part of that system. It's a microcosm of the entire system. And we've seen situations where your guess is as good as mine. Health workers' behavior, the lackadaisic attitude to work, the poor management, because who is going to employ the chief executive? Is the public. What criteria will be used to employ him? Is there any key performance indicator and so on? And we see all that play out in publicly run systems, in Nigeria. Let me tell you this, even in great economies like the United Kingdom that runs a publicly financed, publicly managed, they're beginning to divest. The only thing that keeps the NHS is that it is their identity. Now, this has gone into politics. Politically, the NHS is the identity of the United Kingdom, just as capitalism is the identity of the United States. So no matter how bad capitalism is, America believes that we will sink or will swim with it because it's the identity. So the NHS is a big Waterloo for the British government. They have been looking for every way to divest. They have been looking for how to give it even to private managers, It's been difficult because the British people say this is the only thing we know the government is doing for us. You cannot tinker with it. So the government goes around other means to raise additional funding, especially for those who are immigrants, or non-permanent residents, or even those who want to come in for tourism. The UK is not known for tourism, but they're beginning to see, they could make more money. But I can tell you for free, because it's publicly financed and the government is struggling, access is becoming a big challenge. You know what they call a queue time. The queue time is when you have a need and you've placed a demand on the health system to the point where they now give you the appointment to come. So you may have a challenge that, you got a bad tooth, and then you need to see a dentist. And they tell you, no, for you to see a dentist, you need 3 months. So you have to manage with a bad tooth for 3 months. The other day, somebody wanted to do a procedure, a Whipple procedure, we call it. And then they gave him 6 weeks, before an appointment could be given, so he had to go to private. So when he saw the private guy, the guy had some compassion on him and he said, okay, I'm going to walk you through the system, because he didn't want to do it private, he wanted to do it public. And so he was able to guarantee him. So we see those challenges with publicly financed, publicly provided system. Yes, who else wants to make another argument? Dosumo.
Hello, sir.
Yes, please.
My
Thank
name
you,
is
Prof.
Richard.
I have I have a little, different from either of them, because before we can conclude which is better, we need to really look into for what society. And I'm going to be
society.
So for Nigerian case, we have seen cases of publicly financed, publicly provided. We also have cases of privately financed and privately provided.
Yes.
Especially with the private hospital. So for us to have a fair one, I think having to do it both privately and publicly financed is one thing that we need to look at, but publicly provided. And here's my argument.
Okay.
If publicly financed, we look at, I would like to take three components of the financing. One, infrastructure. Two, equipment. Three, the staffing. Now, if government can focus on staffing, publicly financed, the private entities can come in by investing in equipment and infrastructure. Then the general public can come up with, to reduce the burden of out-of-pocket payment, we put everybody on insurance system. So the public is also financing that.
Okay, let's take this scenario you painted now. The government is of wages.
Yes.
The private comes in to put in investment in infrastructure. What are they getting out of it?
Yeah, so that is why, because people are paying on insurance, so the cost of receiving the care is definitely going to be, greatly subsidized. So the profit from making use of the investment of the private, for instance, we say we have the laboratories, we have the pharmacy that is private. So whatever the people are paying there, so there will be a percentage, sharing between the private and the government. So whatever government is getting from there can be used to focus on the welfare, on the wages and other welfare of the staff. While the private can do that, but for that, I can also suggest that maybe the private can come in with 60% financing, while government can do like 40% financing for that.
So the private man comes in to do business.
Yes.
But he wants profit.
He wants profit.
Does business without profit. Because government, as a welfare system, to take care of the people. And I can tell you for free, government doesn't seem to have a problem paying salaries. The problem with government is how do you run? So in other words, the government of Nigeria has no business being in business because it doesn't work for them. They can put in a lot of money without even thinking, what are we doing? Are we efficient? Are we optimizing resources? It's not in their equation at all.
Thank you, sir.
Let's start from Joseph.
Okay, Prof, I think publicly financed and privately managed will be better due to the lackadaisical attitude of our government workers in handling patients in the hospital and the waste of things at times when it comes. They try to hoard some things. So if it's privately,
so what you're saying is this: there's a government in Rivers State that modernized the primary health system, modern primary health care everywhere.
Yes, sir.
And then we see the way this care is being managed. Now, what you're saying is that get a doctor and say, doctor, I hand over this primary health center to you. You run it and know how you pay your staff. I'm giving you this investment to manage. I'm going to grow lives into your practice. You understand? And of course, you know that if practice where people have a choice to move to other providers, you understand?
Definitely.
At the end of the day, how do you expect that system to work?
No, if the government is financing, it does not mean
it's not. The government is financing by ensuring the payment system. In other words, government is now seen as a buck buyer, either through taxation or through the social insurance system and so on. So they're buying services, from the private hands. So the issue of it's not a problem anymore, because people can walk into their GP or their surgery and get whatever they want, and then the surgery puts in their reports, and government reimburse what have been spent. You understand? How do you think that will work in our context or setting?
Okay, looking at it in our context, I want to view it from funders abroad in relationship to the HIV program that we have in Nigeria.
Yes.
Every cycle, we are being funded by either the US government, the British government, or any other government that decide to fund the HIV program. They don't just give us the fund to carry out the program and to implement the program. From time to time, there's always a supervisory visit to see how this fund is being spent, the impact that it has made in the life of the citizens that they're spending the money on.
Who designed the program?
Actually, it's still the founders.
The founders.
Yes, sir.
And
yes,
the founders are interested in sustainable development of your system?
To an extent. To an extent.
But we read out the statistics where we did the multivariate analysis and looked at how outcomes with respect to the building block, including the finance building block, and you saw where ODA came, that ODA has negative impact, on our positive health indicators, a positive impact on the negative health indicator. You saw that picture very clearly, So typically, we don't have sustainable development from funding. They may have some stopgap output because he who pays the piper dictates the tone. They tell you exactly what to do. You may not
I agree.
I'm interested in mosquito control, but all I want is insecticide treated nets. I'm going to be producing that. Funding is tied to the production of overseas production of insecticide treated net, and they just come and dump it. You just have to be using it. The question is that what you would have loved to do, or is that your best strategy for taking care of malaria? And you see, we've been talking about donor-funded or vertical programs over time, and we don't get any headway. So if we put Africa on one side and put Asia on another side, you see the issues around funding. In Asia, which of course in Nigeria we started doing, we now have development plan. We now have a central coordinating system, for funds. Before now we just get derailed. Anytime the funder does the money, we all run into that area.
And squander it.
Big problem, but I think we are coming of age, and so some of the fundings are now moving to East Africa, and other areas. If you are not contributing, can you mute? If you are not contributing.
Then when I was in Abuja, I was with my mom's sister.
All right. So if you contribute, you unmute yourself. Yeah.
Yeah, my name is Richard.
Yes, Richard, go ahead.
Firstly, I want to say I will have to take my view to be a balanced view for the combination of both models.
Okay.
I think public financing will ensure equity and access for all the essential services. Then that can also be combined with a private financing plus provision that will give the people more choice and a higher end services.
So the private will give them more choice, you mean?
Yes. I said now
the private will give those who are able to subscribe to the private more choice.
Yes.
Quicker access.
Yes.
And in a way, try to reduce, the struggle with the public.
Yes, sir.
Okay.
Yes, so I think there should be a balance, a mixed system that will be better off than just
when you say a mixed system of funding, what about provision?
Yes, there should be a private financing and provision. That's what I meant for the second round.
A mixed system of financing and also a mixed system of provision. Is that what you're advocating?
Yeah, that's what I think will be sustainable to some extent.
Okay.
Yeah, it's just my thought, anyways. But
no,
sir,
we're in a discussion. There's no right or wrong answer. We want to see what do we think will work best.
Yeah, I'm trying to juxtapose the two scenarios. That's why I said that that can be a better approach to some extent.
Okay. Yeah, I agree to the extent you say if you want universal access, you are looking at a publicly financed system. And honestly speaking, if you have a publicly provided system, you will have a challenge, just like the NHS has. And as of today, there are many more private practices coming up in the NHS because they've already reached that point where they are challenged. I told you about the queue time. In certain systems that are less dependent on immigrants and so on, you will see that the system is still fairly strong, like you go to Scandinavia. In the Scandinavian area, you see a country of 5 million, 6 million having a kind of infrastructure you will not even see in a country of 200 million. You understand? So people have access, to healthcare. In fact, in Finland, at least when I was there, if you have a challenge and the system because there we're not talking about policy, we're talking about legislature. Everything is legislated because there is citizenship democracy. So if it is how long you have to wait in a GP or in a hospital, it is legislated. So every hospital tries its best to make sure that no one sues them by falling, So your appointment system, your what we call resilience systems, you put them in order. If a staff is not going to come to work or a group of doctors have gone on strike, immediately you know your contingency plan. You evoke it. Now, the rule says that if you place a demand for a service, let's say dental service, and within 1 month you are unable to get a placement, appointment in any of the facilities in Finland, get to Estonia. Get it done. They bring all the bills, including your travel bill, give it to the Finnish government, and they will pay. They will reimburse. You understand? But if you look at the NHS, the way it has become, it's been a clog. Because you see the appointment system, because of the queue, for people that want a particular size, is not there. So I will agree to that extent that the private provision in such instance can enable the rich, the wealthy people who, in addition to having contributed to whatever social insurance, mind you, UK deals mainly with taxation. We're going to come to that. UK is mainly a tax-based system. But in addition to contributing your tax, your NI, you can decide to say, I want to go and get a private insurance. So by doing that, you have made contribution for the general good out of solidarity. And then you have used your extra money to go for private so that you can relieve the burden on the public for those who have no other choice than to use the public. But when we talk about efficiency, we want to know what are we churning out in our units with respect to facilities. You understand? You go to a teaching hospital, for example, where you have 400 doctors. What are they churning out? You understand? Is there accountability? But if you go to a private hospital and you are not needed, you are not needed. Nobody will employ, nobody would want to see someone come in and sit down or operate, like we do, we know in our health center now. Many health centers officially will open by 10, sorry. And by 12, they'll tell you if you come there, oh no, we don't want to see again, and we are closing. Who does that in private? Do you think a private shop would do that? So if you tell the doctor, say, doctor, this health center is not your own. We have given it to you. Manage it. You have to pay the salary of the nurses, of all the other health workers. And then whatever comes, it's the company's profit. How do you think that place will be managed? To be managed with a high level of professionalism. They want to ensure that patients' needs are met. so that will encourage more patients to come to that practice. And this is where many countries are beginning to get it right. If you go to Canada today, you go to Australia, you see the same system I'm talking about. The worst case scenario in Australia is the fact that there is co-payments. You understand? But it's still largely privately provided. And when I talk about private, I'm talking about the primary health level. You know, private individuals sets up practice. And then if you come into the practice, the bill may be $100 per visit. The government, the system pays 50 and you pay 50. In fact, there are even some places that will tell you it's all about the system. So they don't charge up to 100. They say $50 per visit. A visit is 30 minutes. 30 minutes. Some people say, look, 30 minutes they come. And so you see a lot of people going into this kind of practice because they know that once they submit their report, they get reimbursed, you know, by the public funds, you know, that have been made for that. So in other words, there is access, but it is through a privately delivered, publicly financed system. So everyone is working for his or her money. Yes, Fatima.
Okay, sir. Sorry, can I still ask something? Still,
Yes,
Richard.
Okay.
So in a global best practice and also in Nigerian setting, you are advocating that it should be publicly financed and privately provided. Is that what you meant?
But that's not what I'm saying. That's what I'm saying. We are making argument for each of the 4 quadrants. You understand?
Okay.
And then we've also made argument for a mixture, especially of financing aspects. And then we'll make argument for a mixture of the provision aspect. But the reason for that mixture is not to crowd the public health system. Because as of today, people are not covered. By the time people are covered, there will be more demand for healthcare. And that talks about the elastic aspect of healthcare. You understand? Many people today have health needs, but they do not translate it to a demand. A demand is where you recognize your perceived need and you have what it takes, as well as the willingness to make things happen. So you place a demand on the system. By the time you are able to come into the system, you understand, the system, the expert now checks you and validates your need. In that way, it is no more your perceived need, it becomes your normative need. And once that need has been validated, the system may have what it takes to solve the need. If they do, it becomes a met need. If they cannot do, it remains an unmet need. So you have to keep chopping, either go to a higher center to get that need met, as the case may be. Now, if we agree everything should now be public, you understand, and then financing restraint has been removed, the drove in the public will overwhelm the public. You understand? So the reason, the argument for now having a mixture of private and public is so that those who have the extra means can opt out of the public, so that those who do not have the extra means can have the space to go and use the public. But I can tell you that with private, there's more efficiency than the public.
Okay, sir. So I have a question. I'm aware of a World Bank funded malaria impact project in Rivers State. I have a first-hand information about what I'm saying.
Okay.
They have been here for over 2 years. They actually granted the contract 2.5 years there with possibility of extension. Now, what they do is this is the information I have, that they gave the fund, the donor, they actually met River State government, and they asked River State government, so River State government are now taking a loan from them, and they are giving the money in dollars for to fund the project. And at the same time, and at the same time, they send people both from Federal Ministry of Health and from World Bank independent verification agents to come and verify, do
So
hands-on.
who determines the strategy?
So that's what exactly I want to ask, because
Who
those
determines
kind of
strategy?
is it sustainable? Is that how it's supposed to be?
No.
Or are we
Who
becoming
determines the
more and more?
strategy for malaria eradication through this funding?
With what I know, I think they are actually working together, the state government and the donors, the World Bank guys.
Okay, so what is their core strategy for the control?
Basically, what they do is to provide all the anti-malarias, the awareness campaign, and all the funds needed. Then they
provide anti-malaria chemotherapy.
Yes.
They provide what?
The insecticide treated nets.
Okay.
Then they send it to all they service all the primary and secondary health centers in River State, in the 23 local government. I'm aware they are actually in 5 states in the country.
Do you believe in all sincerity as a public health enthusiast that the solution to malaria in Nigeria rests with those interventions you're talking about?
I'm being a bit skeptical because
because we know how countries grew, especially Western Europe. 200 years ago, we knew what they were, what the kind of health challenge they were having. And what has really improved those systems are environmental.
Sanitation.
Improve housing, improve sanitation, improve water supply,
exactly.
Building healthy streets, healthy cities, and so on. And then somebody comes to tell you, no, your problem is fall ill of malaria and come and take medicine. You understand? And even there was a time we were promoting insecticide-treated nets. I was in government then, and then I saw loads and loads of insecticide-treated nets. And so we mobilized to give families, both pregnant women, everybody. And then the people took it and just hid it because they said, no, we don't like sleeping on that net. You understand? Nobody asked if nobody did a demand creation. That's at that time. There was no demand creation. We just felt this is the solution. When I talked about the generation of reform, I said we've got a generation where things should be demand driven. You understand? You don't tell me that my problem, you tell me my problem, as well as give me the solution. There must be co-creation. There must be a way that you bring people, into creating solutions for what works for them. But most times you have donor funding, they already have what they want. Either defined technical experts, or what the country's interest is. Your country's interest may be to improve your industrial output. And because you want people to be at work, if there's low industrial output, people will go out of work. So instead of paying people social security, you say, go back to work. When you produce, we will send it to poor countries, and use that to donate to them so that poor countries don't have the immediate need to set up industrial mechanism to solve some of the things they think they can solve, because the donors are doing it. We need to look beyond, so-called the gift, and see how this affects our system. Many countries have grown not out of vertical program, but out of embracing comprehensive primary health care, building systems that works for today and is able to work for generation with all the threats, that may be coming up in the future. And I think we need to also imbibe that kind of attitude, to build. The Black people don't have long-term plan. And if they do, they don't follow it. And because they don't follow it, the donors come, and set the stage for them on what they need to do. It brings temporary relief, but long-term, it brings a lot of distortion, to your system. Okay? Are there still more comments on this, please?
Okay. Hi, Prof. Good evening, Prof.
Good evening.
So, Prof, I still think that the whole duty is still on the system, still on us, the country. And then
It's still
for
on
what
us.
is still on us, the
Yes.
country. Yeah. If we take the absolute responsibility, which is the main thing that is going to change everything that is going on
Okay.
in the system currently. In as
Yeah.
much as we may not think that probably the agencies or whoever are doing the right thing because they're doing it based on what they think we need and all of that. But it's still
Okay.
on us to channel it responsibly to where we need them, isn't it? Then what I
Absolutely.
think, like you made
Absolutely.
mention, is a systemic thing, is for us to overhaul what we need and then, direct whatever comes to our way and then give it to where they will serve their purpose at the moment and then still continue on our long-term plan. When we were talking about the funding and all of those, you see, this thing is just an issue that keeps reoccurring. There has been a lot of strategies coming up, both private partnership and all of that. We keep dumping one and going for another. It's still about responsibility. You tell me the same person being me will be in a public sector and I will not do well. And then I'll go to my private sector and I'll do well. It's still a attitudinal problem that we have. And then if we don't change it, one of these, financing and all of that, it will still be a great thing. You see, for a common good of the country, public sector should be under high surveillance, and somebody should really be given what it takes to supervise those under them. And if you don't need it, you don't need it. And then until we come up to raise
So, but
leaders,
do
even
you
in
think
public health,
in conversations like this, and that's why I like people that are broad-minded, the conversation is not what we can finish in one night or in one day. And it's not an easy fix, I must be honest with you.
That's true. That's true, 100%.
Sometimes being in the milieu, you may not know the dangers. In fact, sometimes we hear the word Nigerian factors. None of you will want to research into what a Nigerian factor is.
100%, that is the problem.
You understand? Because sometimes you think the problem may not be donors. The problem is the culture of the people, the way we do things.
Yeah.
So if we all have the mentality, everyone for himself and God for us all,
Yes,
move this country forward.
That's true, sir. 100%. Yeah.
I am managing a fund, a donor fund, and then the donor gives you money, and you say, this is what I want to do. He said, no, do that. You want to put up sustainable structure that after the funding you can be able to say, no, don't do that. Don't do that. So what do you want them to do? Use the money, travel, or run programs, and all that. At the end of the day, you leave with the money, and then the money finishes, and then nothing goes on again. We close shop.
Yeah, that's true.
You understand? We must have that cultural shift, where we look at things and we have that long-term orientation instead of the quick fix or quick fixes that we have hitherto been bothered about. We'll have more discussion and conversation around this because financing is a very important issue.
It's very interesting.
When you look at the common forms of financing, you will see that we have 5 major forms of financing, 5. There are a couple of others, but these are major. So if you look at systems across the world, you will see a predominant, no country runs a pure financing system. There's always a dominant, and there are others, that are, and the reasons are easy to understand. You can't keep one system, because government, no matter the resources you have, you cannot meet the needs of everyone. So we have the one that comes from general taxation, and it's called the beverage system, or it's called the public health insurance system. Then we have the one that comes from the social health insurance system. Now, in this one, people contribute based on their ability. When it comes to taxation, in places where taxes are efficient, there is no exception from the tax dragnet. There is no obsession. If you go and buy toothpick in a supermarket and then they give you your receipt, you see that 22% has gone in to the government as tax. So even if you are buying it with £1 or $1, you're actually contributing 22 cents to the government. So for the fact that you are a consumer, which everyone is, you are a taxpayer. But when you come to systems that are not efficient in taxation, you find out that it's only those who are in the public sector or in the organized private sector that are really paying tax. Although we have multiple forms of taxation in this system, but many do not pay. And that is why I think the government is doing a lot of tax reform to see how to improve, its ability to collect tax, at least get a level where you can say your tax to GDP ratio is optimal within the sub-region, and things like that. So if you run an efficient tax system, the general tax method, which is the beverage method, would be your best bet. And that is the example you have in the United Kingdom. Then if you run the social health insurance system, if you're a socialist country, this is another way to run it. And this will mean that will come to contribution later, but the social insurance system, the goal is to cover everyone, irrespective of your ability to pay. So that is where we talk about the cross-subsidization, where I say this rich people pay more and use less, and the poor people pay less or almost pay nothing and use more. Then we now have Hello, can we mute our sister? We now have the private health insurance method. This is the one that is now, the private man is a businessman, so he does this through a process of cherry picking. He goes for his right candidates. And the right candidates are those who are the money bags and who have less health needs. So for you to get into a private health insurance, they first profile you. And based on your risk, they will not tell you what to pay. So in other words, there is no equity when it comes to private insurance. You pay based on your risk. In fact, if you're on a certain premium, and then they observe that you now have a risk, let's say you now develop diabetes, they will tell you, oh, you're going to use more of the system, or so we are going to charge you more for that. But in social insurance, nobody looks into your risk. No one profiles you. If you are offered a baseline health check, it's just for them to know how to take better care of you. It's not to decide your premium in social health insurance. But in private, it's to decide how much you have to pay. Then the out-of-pocket method is the one we pay at the point of access to healthcare. It's called the cash and carry method, and I believe this is the most destructive, which we will discuss later. And then you have the community-based financing, which comes in different forms. You can call them mutual funds, community funds, or whatever. But it's called community health insurance program, where a group of community, by definition now, is within a territory, decides, pool resources together, and then provide or purchase healthcare for themselves, either through established healthcare providers in the community, or through a managed care system. They can all do that. So these are the 4 basic types. And if you look at this slide, yes, I gave an example of it. For the community-based health insurance, Rwanda seemed to be the example. The question is this sustainable? Is this sustainable? There are a lot of stories going on, around this. But the good thing about health insurance is that you can always, healthcare financing is that you can always see different countries that have implemented different things, and you can be able to learn, and know whether this is the right thing for your system, whether it's the general taxation, which UK NHS does, or social, which Germany is doing, or what the NHIA is promoting, or private, which US is doing, and then or community-based, which Rwanda is doing, or out-of-pocket, which is a dominant method, in Nigeria currently. We need to look at it. But generally, the basic model of health financing is that we need to collect, we need to share risk, and we need to purchase. You understand? And it takes a system to do that. It's not what families, household, can do. It takes a complete system to be able to pool risk. And this is because our risk differs. If you look at this chart, you will see that the cost of healthcare, is so much at the extremes of life. At the extremes of life. So very young age and very old age, they take a lot, of healthcare. And also we see all those issues I have discussed about the unpredictable demand, the uncertain outcome, the externalities, and so on, they happen. So basically for you as technicians, if you are called upon to say, design a system for us, you want to do an actuarial analysis. An actuarial analysis just to advise you on what kind or what size of finance budget or what quantity or what amount of money can serve in a way before you even start talking about where will this money come from. You understand? And so talking about that, we want to know in the community, what is the illness pattern? And what is the risk or the tendency of people to fall ill? And if they do fall ill, how much does it cost? So when you're able to do that, you're able to say, okay, on a balance of probability, that's on an average. This is not what you're going to be, but on an average, people fall ill at social times. So looking at the general population, if you times that and then you now look at the amount of money you need, you know what people should be paying as a premium. When you get what people should be paying as a premium, you can now know how to now get that money from them. And in getting that money from there, you decide on whether you want a progressive, a regressive, or a neutral form of financing. You understand? Progressive form of financing are the one that as you earn more, you pay more, but it's still not a fair system. Let's take, for example, I say for health insurance, everyone should pay 5% of his salary. The implication is that if your salary is 100,000, you pay 5,000. If your salary is 1 million, you pay 50,000. Now, even if you have paid 50,000 in 1 million, you still have 950,000 to go. And the person that has paid 5,000 from 100,000, now 95 naira. The question is that, what do people need for subsistence? I mean, to take care of themselves, pay their legitimate bills, including the house rent, the food costs, the school fees, the taxes, the levies, including those who pay tithes, and all that. What do they need to do all that? And if you subtract it from what they get, what is left? Now, what is left after you subtract your subsistence costs from what you get is your disposable funds. Now, in that disposable funds, you now decide what you want to do. And you may think, I want to go for an exotic experience, or I want to go for a holiday, or I want to go to a party or to cinema or all that. Now, the idea is this. There are so many people that do not have that disposable income. In other words, their take home cannot take them home. And by the time you now put up a 5% flat rate on everyone, you are pushing such people into worsening poverty. Because every month they have to collect or borrow or sell or do one thing or the other to be able to meet up. You understand? So the Kapani Index helps us to know whether it's a progressive way of listening or it's regressive. So you know the various forms of progressive and the various forms of regressive, and also the neutral. Now, just you look at it this way. If I say, let me give an example. Where do I give the example? I've given the example of flat rates, which is progressive. Progressive. Now, if I say that we are dealing with, in a way, that's not progressive. In a progressive way, everyone, like the Nigerian tax system, if you earn 200,000 annually, that is your non-taxable income. The moment you go beyond 200,000, you now have the various bands. If you go to the level of, let's say 500,000, the government can say it's 5% of your income. If you go from 500 to 10 million, they can say it's 10% of your income. And it goes on in that graded form until it gets to, I think the highest tax band is still about 40%, Hello? 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 So it goes to about 40%, of earning. And people, hello?
We can hear you, sir.
We can hear you, sir.
We can hear you, Prof.
Yeah, I already had a distraction at the background. So some people who are supposed to be honest enough to pay that, they would rather use other means. You can be a billionaire now and say, I earn no salary. You understand? My company is taking care of my consumption. So if I want a car every day, the company buys the car. You understand? So people want to put that into the company expenses. You know, they want holiday. They say, oh, I'm going for a training. I'm going for a retreat, you know, to boost my company. You put all kinds of things. And at the end of the day, you are not paying. And these are all, especially when you have smart accountants, they know how to do this. So you can decide between what is progressive, regressive, and neutral, you know, based on the way it can pull people into, that it brings equity in the system. Health systems, like every other systems, tries to ensure that the society comes back to becoming an egalitarian society. So if the society has been abused by the tendency that some people become super rich and some get too poor, systems try to see how to get more from the people that are super rich and then use that to help the people that are poor. And that makes a fair system of financing, you know, basically. And if you go through the fairness of financial contribution I sent to you, you will know how to calculate this based on either the total income, which is 10%. If you spend more than 10% of your total income on health, it's catastrophic. Or you go through the non-food income, which is 40%, you know, you'll see all that there. And so you see those examples, like I said earlier on, and how they play out in all this. And the community health finances, you see a lot about it. The progressive, like you talked about the income tax, the tax waiver of low income group, the property tax. Property tax will increase the tax of rent, basically, you know, and you know the effect that will be. For regressive, we look at the proportionate tax, the consumption tax, which everybody pays the same. In regressive, everybody pays the same, but it still doesn't help the poor, the out-of-pocket payment. And then in neutral system, is the closest to it is the social insurance system. You know, that looks closest, you know, because you are not expected to pay if you are under a certain limit, you know, but in Nigeria, the case is not so. I think in social insurance system, basically in Nigeria, really runs like a progressive kind of taxation, you know, not neutral. Now, the question is that, is it ethical to buy health services with one's own money? We can leave that debate. You can have it and look at it. But when you consider the various financing alternatives, there is a yardstick for knowing how good a financing system is. And these are the indicators you use to check that, especially if you are able to, within a short time, change if you think this is not working well for you. That's the displacement effect. You know, it's very important to use this to assess the financing system. The principle of good financing, according to the WHO, is that there should be equity, there should be efficiency, there should be transparency, and that's why you have finance as trust. So state or federal can run health trust, you know, where they know that there is absolute accountability and transparency, and there must be sustainability as well as financial protection. There are issues with financing globally and more so with developing countries because developing countries are under-resourced, you know, and with the mirage of health challenges and low financing, it becomes a challenge to provide health. And so if you look at the Nigerian context, you see that out-of-pocket is still the bane of our health under development. And I think one of the reasons why this came about, you may not agree. You know, in the early times, especially when we had the basic healthcare provision funds in the late 70s, 1975 specifically. Now, they found out that government was not meeting up with its responsibility. You know, they were out of stock, you know, in especially at the primary healthcare level and so on. So WHO Afro had to gather the regional government together and say, let's think out of the box and solve this problem. And so in 1977 in Bamako, as a means of strengthening what you call safe motherhood, they said that, oh, why not we put a cost, the consumable. The way it is worked out is that you put the cost of the consumable and a markup. People pay that, and so that you can use that money to finance health services, especially critical health services for women and children. So moving on from a non-paying era, because government cannot, into a paying era where you have to pay for your commodity, was a bit of it took some time, but it worked. But now we have outlived the usefulness of Bamako initiative. It is now so difficult to bring us back, and well, we must be responsible enough to be able to save for our raining day, make a contribution, get insured, and all that. It's becoming very difficult, to do that. Nigeria is one of the countries with the highest level of out-of-pocket expenditure. If you look at Ghana that started insurance and social insurance after us, they have well gone far, far, far ahead of us with the proportion of their population that are covered, by the social insurance. There will be a debate and say, what is going wrong with the Nigerian system and what is going for other countries that have been able to achieve, this feat? These are discussions and conversations we need to have, But if you look at, hello, somebody wants to say something about that?
Yeah, I'm in class. I want to take that king. Go ahead. You guys. And it's night now. Yes.
Maria, you are starting the class.
Okay.
Mary, please move.
All right, I see I have the right. So we look at it, you look at the challenge. The challenge in Nigeria, issue of fragmentation and inefficiency in the flow of funds. You have the state, you have the local government, you have the federal. Who is doing what, when it comes to healthcare? How do the funds flow? I once said in the state I work that the state fund for healthcare is like cryptocurrency. You don't see a budget and you don't see a report at the end of the year. You understand? And so that tells you that the basic act of governance is missing. You understand? So you don't see a budget to tell you, oh, this is what government is going to do. And at the end of the year, there should be a report that stakeholders will have and say, this is what we have done. You understand? As a matter of fact, when the National Health Act was, the National Health Act came in 2014, but it was not implemented. It was signed into law in 2014. It wasn't implemented until the National Assembly in 2018 on their own overruled the president and made sure that the budget for the provision, that's the basic healthcare provision funds. And when they did that, between 2018 to 2022-23, it took a long time for the health system to absorb that funds because the health system lacked capacity to even absorb funds. They lack capacity. Because funding is not something easy. Sometimes we think it's easy. Think it's all the politicians do, just put 10 billion, 10 billion, which is stolen. If you want to carry out a health action, it takes a lot of processes. And so the system plans would have been developed, structure would have been put in place. You understand? Merely telling people and say, okay, get the structure right. Make sure you have primary healthcare under one roof, let's say, as one of the conditions. Make sure that you are able to get this. We call it conditional things to be met. It took a long time for many states to be able to do that. You understand? So you see, the issue is not only about is the money there, it is about the capacity of the system to even absorb the funds. And we also have weak enforcement of mandatory insurance because by 2022, when the National Health Insurance Act came on board, one of the provisions was that health insurance is now a mandatory exercise, meaning that every Nigerian must. It's not a matter of whether you like it or not. But the question is that even with that provision, why are we not getting it? It was just last week that the president gave another directive that all MDAs, and yes, only speaking for the federal MDAs, must ensure that their staff are enrolled. Yes, I must take the president to do that. The law says this is a law. You have to do it. Why are we looking for the presidential veto or powers to make people do what they need to do? And there's also poor data on health expenditure and outcomes and limited financial literacy in the system. Many people don't trust the system. And I can tell you that is a big problem between state and federal. There's a huge distrust, between them. That state believe that if anything that is federal, the federal uses its might, to determine what to do. In many cases, even abusing those things. And so states will want to pull off from what is federal because they know they cannot fight with the federal. All right? So the last thing is the financing system is strategic purchasing in health. And this makes it cheaper. And such processes through the NHIS, for example, goes through capitation. Now, capitation are for general enrollment. You enroll number of heads, you get this amount, you prepare for them. They may not come. You understand? So the capitation is paid whether they come or not. And then the fee for service is what you now see people do and apply for reimbursement. You understand? And then there are also performance-based financing. These are incentives to make sure that providers meet up with certain targets. And when they meet up with those targets, they are giving funding just to encourage them, to keep doing well. So clearly, this is a consensus. You may not believe in it, but this is a general and an emerging consensus within the Nigerian space. Now, what it says is that market-driven, privately financed health insurance alone cannot result in universal health coverage. Do you agree? Those who agree say yeah.
Yes, Prof. Yes, sir.
Yes,
And those who don't say nay.
yes.
I agree, sir.
Yeah, have it.
Yes, sir.
Yeah.
Number two consensus is that government must force the healthy rich to subsidize the sickly poor. Those who agree say yeah.
Yay.
Yes.
Those who do not say nay.
Yes, Prof.
Nay.
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 Let me hear from those who say nay.
Nay.
Why say nay?
Nay.
Why?
Nay.
Somebody should tell me why nay.
Okay. Thank you very much, Prof. This is Fatima. I don't totally agree for the government to force the healthy wealthy to pay for the sickly poor and to even enforce it as a policy for two key reasons. The first being that the assumption that the healthy wealthy is an absolute condition and is permanent is a fallacy, because health status as well as the wealthy status is dynamic. And then the second part is the undue feeling of entitlement and lack of drive to self-improve that brings upon the sickly poor, who begin to sort of put a demand, without putting anything else on the table on the public, just because they are richer than them. So I think there should be a balance, because fairness is not only to one side of the divide. Fairness should be universal, and there should not be sort of kind of a punishment for being wealthy, nor a concession.
We agree to that, Esther, but do you know the rationale behind this? You know the rationale behind this?
No, Prof.
Okay, the rationale is that when it comes to healthcare, we are in it together. So no matter how rich you are, the fact that someone cannot access healthcare should be a problem to you, because when we looked at externality, you saw what happened. Let's assume I am poor and I go and contract a communicable disease. That becomes a risk to everyone. You understand? So the more you help me, you're not helping me because you like me. You are helping me because you don't want that thing to come to you. You understand? So you are helping me. It's more like you are helping yourself, because if you don't do so, what goes around comes around. So what you're saying is that the system, the public system, should have a way of getting money from the poor, from the rich, who may not use so much of healthcare, and using it to pay for the poor who needs that healthcare, so that ultimately everyone has the basic healthcare they need. You understand? So you may be looking at it. What is the preparedness
Yes,
of
so Prof, the other aspect I have is the abandonment of duty on the part of government.
Who is government?
Maybe not government as
government?
structure or governance, but
Who is
those
government?
who have been. Well, if we put it in terms of democracy, like in Nigeria, is the people. But when I talk about government, functionally speaking, is those who are primarily responsible or have the duty to be able to make that provision. We all know how much of the level of corruption and how that has affected quite a lot of the way government distributes resources across
Fatima,
board. It's because it's
let me
one thing to collect, and it's another to dispense.
into use. Okay, but let me cut it short a little bit. Are you aware of the per capita GDP of Nigeria? Correct? The statistics are there. Are you aware of the per capita GDP spent on health? That is how much the government spends on health for one person. If you are aware, the question will now be, do you think that money, which is calculated from your GDP, can guarantee health for anybody? Don't make mistake. Healthcare is expensive. We are only looking at cost-effective way of delivering it. In itself, it is expensive. The NHS, like I told you, the Britons are trying to keep, is costing them about 20% of their GDP. Who does that? The Abuja Declaration says 15%. You see that most countries, including Ghana, Nigeria, India, they are still hovering around 5%, 6% of their GDP because they are competing needs. We know Nigeria is a corrupt society where you have strong men and weak institutions. So you may be hearing somebody has taken 10 billion, 20 billion. But you see, that money, if you are in government sitting on that seat and you know the problem of the society and you see the amount of money you have, I'm sure that's what gives people to be discouraged. Say, let me just out of despair, waste this money because I don't know what else it can do, for the people. Countries of 5 million people have greater GDP than Nigeria. You understand? So government needs to think out of the box. It's a common saying that government has money because we hear that people steal money and we see them flout what they have stolen. But that doesn't mean that government has money. Nigeria is it's a lower middle income country. If we have money, we should be a upper middle or a high income country, but we are not there. Do we understand? So that's why the system was designed a mechanism where the healthy rich will cross-subsidize the sickly poor, and that's not because they love them, but I said out of solidarity and out of being careful so that it doesn't come to you. If there's a Lassa fever outbreak, which we frequently have, it can affect everybody. It will not differentiate between the rich and the poor. So the more we get people out of poverty and secure their health, the better for us all in this climb. User fee are the worst way to finance health services and should be reduced to the barest minimum. Do you agree with this?
Yes.
Yes.
Okay. Private voluntary insurance, including community-based insurance, is ineffective and inefficient and inequitable in assuring access to healthcare. Do you agree with this?
Nay.
as we've discussed, yeah.
Say what you don't agree with. Speak up. It's a discussion. Hello.
Good evening, sir. This is Loretta.
Loretta,
Yeah, sir, I agree with as far as the private voluntary insurance, but why is community-based insurance ineffective?
Tell me where it's effective, and I'll tell you the factors that make it effective. So long as you don't have enough pooling system, including if your state decides to run an isolated insurance system, it will be ineffective. Humans are mobile. You move from one place to the other. You understand? And if you don't get enough pool, you cannot be able to dispense with risk.
But sir, what if you get enough pool? Because I think
you won't get enough pool to community.
Okay, when you mean community, can it be a state, a whole state, or you're talking of a small community?
Yes, I'm even saying that even if a state runs an insurance that is not integrated into the national insurance, it won't work.
Okay. Okay. Sir.
You understand? You are here today, you want to go to Zamfara State tomorrow, and something happens to you. And you tell them, oh, my insurance is in my state. They tell you they don't know anything about that.
But sir, sorry, are you saying that the reef ship will be ineffective on the long run? Because I think reef ship has been able
and other state agencies are integrated into the national. They don't work in isolation.
Oh, okay, sir.
They are guided by the national, they're integrated. So they provide for those mobility.
So, sir, sorry, but can you also do a community base that is also integrated into the national? Because I think in Nigeria, it's easier to get people to be involved when you break it down to their communities.
But when you break it down, what happens to the administrative cost?
You said it.
Okay.
Because the more decentralized it is, the more the administrative costs and the less we put into actual payments. Don't get me wrong. If you go to systems like you see Reef Chief, you see other states, even in the UK, you have NHS Scotland, NHS England, NHS Wales, and there are nuances. You see that they are especially the benefit packages are different. But they are integrated in the way that when you move from one place to the other, they know how they settle themselves.
Okay, so that means they are not completely bad and they can be refined so that...
Absolutely. Absolutely.
Okay, thank you, sir.
So integration is very important. So what you need to do, if you go back to those criteria I gave you, for assessing healthcare financing system, you see how each of them, just use that as a lens, you know how to do. So public financing, which could be a combination of tax financing, social insurance, and other forms of public financing, is the key to universal health coverage. Agreed?
Yes.
Okay.
Agreed, sir.
Yes, how do we achieve universal health care through public financing? You see some of the things that we can do. The government may give more from its budget. We will need to expand social insurance to the informal sector, to states which you call the various states are not doing it, to the organized private, to the unemployed. There should be full coverage for vulnerable group. There should be special budgetary allocation, like we have, just like the Basic Healthcare Provision Fund has done. We also have the River State Contributing Health Protection Fund, which the government puts in quite some money. Other local government and other entities can do same. They can reallocate public funds to health, especially the removal of fuel subsidy, put into health. The government may consider introducing sin tax. They've been looking for ways of creating more tax, including petroleum tax and so on. I think one way to do that is to introduce a sin tax. A sin tax has some ethical foundation because if you take things that are injurious to your health you end up putting more pressure on the health system because you need to come for healthcare and so on. So by government adding some tax into those things that are injurious to your health, government is by way preparing for you so that you can, when you come to the healthcare, you can also get what you need, you know. But surreptitious is actually meant to discourage people because once the cost is high, the demand is supposed to come down. But again, some of these things are becoming fairly inelastic, you know, as well. There must be improved management of financial resources, including transparency, proper budgeting, and budget implementation. There must be efficient and equitable pooling of resources, which you see in bigger systems like in the states or at the federal level. There are demerits of private insurance, and this is because of the fact that it's optional, it's voluntary, it's selective, there's moral hazard, and then it lacks cross-subsidies. So these are some of the demerits of private insurance. And then when it gets to global trends and innovation, when it comes to insurance, is that there is a move, you know, to use funds to purchase services based on population needs, you know, and value for money. What does the population need and how is it being provided? You understand? And then for us in Nigeria, the strategic options, I've said it earlier on, the National Health Insurance Authority, you're going to read that up. It has a lot of provision, especially the last revision. And then any question on this? I have another slide, which I'll take a few of it, just explanation. And this is how we look at health systems in trying to analyze health systems, looking at the methodology and also the usefulness of each of them. There are various indicators that are used to assess health. And the same indicators can be used to compare, you know, health status, health systems, health determinants from one territory to the other. You know, so that's one fact. And this has been established. And then we see the relationship between the goals and the functions, all looking towards health. So if you look at the goal of the health system, which we defined in terms of goodness and fairness into 5, you see that on one hand, you're looking at attainment. Attainment is what a country is able to achieve without looking at the cost at which it achieved that. What have you achieved? Life expectancy is 80 years. So it's better than someone that is 60 years. But the next question you now say, what resources are at the disposal of the country that has 60 against the country that has 80? So in doing an economic analysis, or generally, we try to look at the input and the output. We don't just look at output only. It gives a fairly wrong picture of what we need to do. You know, so looking at attainment or achievement, as the case may be, it give us a wrong picture. So we need to look at performance. So in health system assessment, we can do the attainment, we define what is achieved, and not looking at what is resources at disposal. Then in performance, you compare this, you know, with either with same country that have the same resources or based on the resources at the disposal of that country. And these goals can be either singly or composite goals as we see them. You know, so what we'll be talking about clearly when it comes to cross-country assessment is that of performance and equity. And when it comes to performance, we're looking at efficiency. How efficient is the system? And when it comes to efficiency, you'll be looking at both macroeconomic and microeconomic efficiency. Macroeconomic look at the greater scale in the country as a whole. Microeconomics looks at the smaller scale, looking at household economy, or unit economy, micro. But when it comes to micro, again, you now have to look at two important indices. One is the technical efficiency, which means what strategy. Earlier on, when the gentleman was talking about malaria control, we asked what strategy. You understand? In planning generally, we must understand strategy, we must understand alternate strategy, and we must be able to assess strategy, compare strategy to know what is going to give us the greater mileage. So technical efficiency looks at the strategy, whereas allocative efficiency looks at how we allocate money. Is it to what gives us greater benefit, or we use certain indices like politically correct, or things that we need to get greatest rent from. These are all considerations that we need to look into. Now, this chart I was talking to you, I was showing you, just shows the typology of how you can measure systems. So if you look at life expectancy, for example, and you look at it over age. Now, and the red may show you what a country is. The green may show you what a country can achieve. Are you seeing what I'm saying, please?
Yes, sir.
Okay.
Yes, sir.
So it means that the space called capital A is what is achieved, and the B is what can be achieved. You understand? Above what is achieved. And the C is what is conceived, so to say. Now, what it means is that if the country is only able to achieve a space A, it has the potential to achieve this, to go into the space B. So if space B now becomes the achievable benefit not achieved, or not yet achieved. You understand? So it means that all the interventions and reforms or system strengthening that you may want to do will be geared towards making sure that you move your achievement, in the space of B. You understand? So your expectancy when it comes to system strengthening is A and the factor of B, or the function of B. So moving things towards that green line is what people desire. No one wants to look at the conceivable benefit, but just looking at the achievable benefits. Now, when it comes to efficiency, like I did say, we look at efficiency based on what is achieved over, or what is attained over what resources is at the disposal. So on the horizontal line is the inputs, and on the vertical line is the performance, called the output. Now, if you look at between capital A and capital B, you see that B has more resources than A by far. But if you look at the green dots there, it tells you the attainment of A and B. Now, on mere comparison, you will say that B is doing better than A because B is higher than A. But if you look at efficiency, which is small b, which is this one. Now, L means the minimum that any country can achieve, assuming there's no health system, meaning that when there's no health system, not everybody's dying, is going to die. There is a performance that can be achieved. And the maximum means that with the health system doing very well, what can be achieved. So efficiency is now what is achieved, which is small p over B plus C. Now, this is the same thing, like I said here, moving towards the green. So this one, you are moving towards getting to the maximum line. You understand? So B over B plus C is the efficiency of each country. Now, if you compute that for country A and country B, you find out that with clear measures, you find out that A may even be doing better than B when it comes to efficiency. You understand? Am I communicating?
Yes, yes, sir.
Yeah.
Yes, sir.
Yes, sir.
Thank you. So quite a lot of measures we can use. Then when it comes to the, sorry, is somebody? When it comes to the goal, let me know what Adams wants to ask a question. Adams. Adamu. Is your hand raised? Okay, no. Okay, so when we come to the composite goals, when we looked at the 5 goals of the health system, which is overall health status,
You're not muted. I'm not muted.
distribution of the health status, overall responsiveness, distribution responsiveness, and fairness in financial contribution, we looked at it singly. But we can actually get estimate of this across countries and then put up a weighted measure. In that weighting, you see that health status alone gets 50%, meaning that overall health status, which is goal 1, will take 25%. Distribution of health status among population will take 25%. Overall responsiveness takes 25%, so overall takes 12.5. Distribution of that takes 12.5. And this is a measure that has been adopted, by the WHO at least once in 2000 to look at how well countries are doing. You understand? So these are measures that can be. And I spoke about the frequently used, which is equity and efficiency. And I've actually explained efficiency in that context. And I brought it down to microeconomic efficiency, where I talk of technical and allocative. Let me talk about equity. Now, equity is not equality. But equity means treating equal equally and treating unequal unequally. You understand? So equity means that if we are equal, treat us equally. If we are not equal, don't treat us equally. You understand? So you could have vertical equity and horizontal equity. Now, vertical equity refers to equal treatment for equals. Horizontal equity means unequal treatment for unequals. So you are tending to balance this up. So if you look at this picture very clearly, you see that there are 3 pictures up, and it shows 3 different scenarios. Now, individuals have various heights. And so you give them the same pedestal, the same platform, to stand on. You keep their differences. So all you try to do is equality, but the taller person still remains taller, and others still maintain their distance as their relativity. So that is called equality. Now, in equity, you want every inequality to be balanced in that sense. So it is the person that is shorter that you're going to give more support to the extent that he will now be equal to his peers. This is equity. Of course, we know in reality, the rich gets richer and the poor gets poorer. That's the reality. So what that means is that we can now understand equity in terms of horizontal and vertical, and then in terms of the functions of the health system, looking at the financing function, allocating resources, and providing services. In that sense, when it comes to financing, someone should explain what horizontal equity is and what vertical is. A smart colleague in class should do that. What's horizontal and vertical equity in terms of healthcare finance or contributions to healthcare? Who's taking the challenge? Yes, speak up.
Okay, good evening, Prof. So, just like in the example you gave previously, the horizontal equity would be, let's say, everybody pays 5% of their salary as insurance.
That's not horizontal
and
equity.
Then, so sorry?
That's not
That's
horizontal.
those that earn. Okay, so based on how much they earn.
Horizontal equity, what does it mean? You are trying to describe vertical equity in terms of progressive.
Okay. Sorry, yes.
So looking at horizontal, what do you think when it comes to financing?
So like you'd say those that earn 100 to 200,000, this is how much they're going to pay. Those that earn 300 to 400,000, this is how much they're going to pay. Is that what it is?
Let someone else try in the class.
Let me try.
Sir,
Richard.
yeah, I'm raising my hand up.
Yes.
For
Can I say
horizontal,
something?
Yes,
for
let me
horizontal equity means that those people in the high socioeconomic class, like those equals, they will be given the same equal ability to pay. That means the rich people, the high social economic class in the society. So for people that are earning, maybe example, above 500,000, above 1 million, they'll be given equal amount to pay for insurance or for their health. Then for vertical equity now, is treating those people that's giving payment to those people according to their ability, like the medium economic class and the low socioeconomic class, according to their ability to pay. So they might not be earning the same salary, but they'll be able to pay according to what they are earning, like according to what they can offer.
let me hear from
Hello, sir. Can I
Musiru.
speak?
Yes.
Okay, so I think that horizontal equity simply means that those who are equal should pay the same amounts. So
Exactly.
people who are in the same class should pay the same thing. Then
Yes.
for vertical equity, people pay according to what their ability is. So based on the amount they
So
are earning, they
people
can
who are
pay based
not
on
on the
that. So
same
they pay
class
differently.
should pay differently, correct?
Yes, yes, sir.
So it is now we now start thinking, how do we achieve that? Is it through progressive, through regressive, or through neutral? You understand? Income
Yes.
tax, you know, but the difference is that if you are earning differently, you must be charged differently.
Yes.
All right.
Yes,
and so
sir.
take to the point of allocating resources, resource allocation, horizontal and vertical. Yes.
Please, sir. I didn't get you.
Yes, we are moving from financing now to allocating resources. This is from the government or the administrator's perspective. Yes, I see some hands raised. Anyone raising up hands? They may judge.
Yes, sir. Richard. Richard.
Okay, Richard.
Okay, sir.
Okay.
For the vertical equity resource allocation, more resources for people with greater health needs. That's what I think for the vertical. There should be more resources for people with greater health needs. Why
for horizontal is what?
For horizontal, equal treatment for people with equal health needs. That's what I think.
Okay, so it means that if we have the same or similar health challenges, when you are providing resources, provide similar things for us.
Yes, for the horizontal.
For the horizontal.
Yes.
And then in vertical, you know, territories or sections or individuals with different needs should be provided different distance. Let's take, for example, look at the issue of access to childcare. And then you said the idea is that I want to ensure that within the space called a ward, which is the smallest geopolitical division in the Nigerian system, every ward should have a health center because we have children, we have pregnant women that needs to be seen. Assuming but not conceding that these wards were well delineated, horizontal equity demands that every of those wards will have the same health facility because the same kind of people will be coming to see them. But in a situation where some wards are populous, meaning that they are heavily populated than others, they should have more. That is vertical equity. Are you hearing what I'm saying?
Yes, sir.
Yes, sir.
Yeah, what about in providing services?
I think it's almost the same thing. It's almost the same thing.
It's almost the same thing, but when it comes to allocating resources, it's from the manager's perspective. In providing services, it has to be with providers. You understand? These providers, you know, when you get into the hospital, especially emergency care, the triaging is done.
Yes.
Now, the reason why they do that
Yes,
is
sir.
so be able to identify, they're able to identify those who need immediate action. You know, and when they identify that, they will now be able to ensure that they meet those needs immediately.
Yeah, so for vertical equity, more intensive and specialized services should be given for people that have greater health needs.
And then relate it to horizontal.
For horizontal, it's equal. You've already answered that one. Equal access for quality,
for people with the same health
with the same condition. Yes.
Exactly. So you see, in reality, you see situations where emergency cases are abandoned and a big man is being taken care of. That is reality. But if you want to go on the base of equity, if we all have the same problem, we should have the same access.
Access.
Our problems are different, we should have different access.
Different access.
So
Yes,
this is where if you bring in the cross-subsidization, while the rich on the base of financing pays more because he earns more, the same rich will get less access because he has less health needs.
Yes.
Poor, who pays less because he earns less, will have more access because he has more health needs.
Rich.
So we see that play out, you know, in cross-subsidization. Okay, so other areas you could compare countries, just giving you some of the metrics, you can read that on your own, how this has been done. And so having said that, we can look at the typologies. You know, typology is just a framework for looking at countries in different ways because it also used to classify health. And there are 5 basic typologies for classifying countries or stratifying countries. Now, this could be based on the dominant method of financing, and we have listed that out on the tax, the social, the private, the out-of-pocket, and we saw examples of countries in that. It could also be on the basis of how healthcare is provided, whether it's mainly public or mainly private or a mix. You know, the United States is more private. If you go to the United States, most institutions are private, whether university or hospitals, you just name it, they are private, you know, because of their capitalist nature. And if you go to Europe, you begin to have public facilities. You understand? Public facilities. And then you see those that are mixed, meaning on an average, you see both public and private. And then you look at the underlying political philosophy, and countries are identified by this philosophy, whether they are communist country or socialist country or capitalist country, as the case may be. It has implications for health. So when you're discussing health or proposing health reforms, you must bring into context these various typologies. You know, and then we look at the nature of state intervention. What does the state, that means the public, wants to do? Is it selective coverage, or is it universal coverage? Or, you know, countries have intentions to cover everybody. So their strategy and their plans will be tuned towards that. But if, like we do in River State sometimes, selective, your strategy will be, let's take the retirees and take the under 5s and take the pregnant women. What happens to the working class? You know, and all that. So you can classify countries based on what the state intends to do. You can also classify countries based on their national income. Said it earlier, the low, middle, and high. Under the middle, you have the low, middle, and you have upper middle class. Nigeria is lower middle class. And then you could also classify countries based on their historical and cultural attributes, like industrialized, non-industrialized, transitional. Nigeria is a country in transition. So you see, countries' health system are reflective of all these typologies. So if you show me the kind of country you are, if you're a capitalist, I'll tell you to a large extent what kind of health system you're going to be having in that sense. But again, looking at Nigeria, you think Nigeria is capitalist or socialist, or maybe a mixed?
We are in between, sir.
Yeah,
We are a mixed.
Yeah, okay. So you see that play out in lack of structure for our health system. So we've said this before, just putting it in context, looking at funding, provision. The other time I looked at it based on, the funding, but you can see based on provision as well. And then when it comes to universal health access, the key characteristics. So where you have the mixed to pluratic in the sense that this model used in a couple of approaches, you see that the funding is multiple, the provision is public and private. The key characteristics there is that they are fragmented and unequal, and there you see an example of it being Nigeria. So you can look at this and see how this play out, putting the funding system, the provision system. Key characteristics means how do they cover the population? And then you see the examples of those countries. I have described this earlier on. And in this one, in this matrix, you are able to see, based on, again, these attributes of looking at national health system. These are criteria you use to assess national health systems. And if you put the four major financing systems globally, this does not have, yes. So you see that you have equity, efficiency, financial protection, patient satisfaction, and cost to government. Let's take one of them, one of the attributes. Which one do you think we should look at?
Patient satisfaction, sir.
Now, patient satisfaction. Now, in a beverage system, what's a beverage system?
It's more of taxation, general taxation.
Taxation, yes. You see that patient satisfaction is moderate. Why is it moderate? Why not high? Nobody likes tax. And if you go back to that slide, you will see that most of those ones that are taxation, the service provision is public. People don't also like public. Let me tell you this. A poor man has desires. He doesn't want to pay, and he wants to get the best. You understand? So more of this beverage system, are done to communal effort, because this is our thing. And so it's public health distance. So you see that the satisfaction there is moderate. Then when you get to the Bismarck system, whether you get or not, enter. You understand? And so in this Bismarck system, you could even have public, you have private, depending on the country. Their level of satisfaction is high. And then if you go to the NHI, which is the insurance, this Bismarck is social insurance, but this other one has both private and social insurance. It's also high. The out-of-pocket is variable depending on your circumstances. If you are favored, there's no challenge, everything is going on smoothly, you say you're making a gain. But when there's an adverse event, your satisfaction level, because of the challenge you may be passing through. So you can actually explore all this. Please go through all these tables, check through, compare it, you understand, different health systems. And if there's anything, I can talk more. On provisions, I have classified provisions where you have primary, secondary, tertiary, public, private, traditional, alternative, or the orthodox. And based on actors or the philosophy behind the provision, you could have the medical model. The medical model is the one that emphasizes so much of hospital care. The health promotion model looks at how to improve community health through ensuring that preventive and promotive social model goes beyond health to look at all the social determinants of And again, if you look at Nigerian case, I've said it before, but just adding a little thing to it, you see what it is. To understand the health system model, we can actually take on reforms, you know, and then each model, each model is political, social, you know, and economic values, you know. One of the things we have not working for us is we seem to vacillate between capitalism and socialism. We've not had a clear political ideology in this country. But look at what the government is doing in recent times. It shows that capitalism is what may go sway because most systems are challenged, you know, by reforms of the government. So it's only the very rich keep their heads up. For more low-income, low-middle-income countries in Nigeria, we need to adopt global models to local realities. And one of it is looking at a publicly financed system from a combination of tax and social insurance, then looking at the provision being a mixed method of provision. You know, the mixed method is not only public-private, but also encouraging complementary and alternate medicine, you know, and healthcare provision. I want to know if there are questions, you know, from this discourse. I'll send a slide across. I don't see any hand. So if I don't see any hand, I want to appreciate you.
So I have a question. Just one question.
Go ahead.
Yeah, for the malaria, I'm the one that talks about the malaria funded program.
Yes, please.
What do you think, in a nutshell, what do you think should be the right approach in funded program like this?
The right approach is for the government or the system to have the capacity to decide. And this comes through planning. In your next lecture, I hope I am still the one taking it. We'll be talking about planning. Every country must plan. And when you plan, anybody that wants to come and help you will help you based on your plan. They look at your plan and they know where you're coming. They don't want to dissuade you or entice you or do anything. They work with your plan. Nigeria planning. Although if you look at history, before the colonial, before independence, we have the first and second colonial development plan. These are generic plans. They were planning for us. And when the colonial masters left, we had the first, second, third, and fourth national development plan. It was only the third national development plan that created some emphasis on health. You know, I guess through the effort of the late Professor Lukoye Ransom-Kuti. Now, having said that, we were not having any health plan. We're just moving anywhere the funders say, you understand, we are moving. And so we had a lot of that program, and it gave us one of the weakest, in fact, at the turn of the new millennium, we were fought to the bottom. Even if we are having all kinds of donor program, donor intervention and all whatnot, it didn't strengthen our health system. We were the weakest health system. In fact, comparable to war-torn countries like Sudan, Chad, and all that, you know. But it took up to 2012 when we started our plans. First of all, we had policies in 1988. That policy was not strictly followed, you know, because we're still doing our own thing. But when we had the first national strategic health development plan, it was when the national health system started galvanizing, you know, and then then we went to sleep. We slept because that plan was to be from 2015 to 2020. 2020, nobody knows what was happening. 2022, they brought the second, but the zeal with which they did it has been watered down. You understand? After the second, I want to believe by the time we come back, or no, I'm not sure if I'm the one taking in reforms, you know, but you see that the current government is doing something completely different because they have gone away from that trajectory of running the cycle, which are the medium-term framework and the strategic health development plan. We now hear of SWAP, we hear of quite a lot of other things. How this fits in, you know, is completely unclear. And we don't know whether what they're doing will be sustainable, whether another government will come and say, no, we are going back to the strategic health development plan, because that was pretty straightforward. The framework was sorted, it aligns with global agendas, and so on. And I believe that with the consensus built then, we should have continued in that trajectory, So talking about your question, is for the country to have strong systems and let every other person that comes support that system. That's where you could achieve sustainable development.
So in the case of malaria projects, sir,
Yes.
what should be the best laid down protocol for sustainable?
The country would develop a country-wide strategy. I cannot preempt what the strategy will be. If you ask my view, I am more of a system person. So I'll tell you that, look, the best thing to do is get your environment right. If you get your environment right, Nigeria still pay lip service to global warming. We pay lip service to environmental sanitation. We pay lip service to municipal water supply. We are about one of the few countries in the world that public amenities are not there. Public amenities are not there. But you don't even know what the local government is doing. Can you, in all honesty, go to a public market? You understand? These are considerations that should be taken serious. Local government engaging people, cleaning the drains, making sure that there's no breeding, doing area fumigation and all that and so on. And then we come to Nigeria, everybody say, go and fall ill and come and take some pills. Or go and fall ill. And if you talk about the insecticide treated, how many people stay under the net? I don't remember when I had malaria last, honestly speaking, but I can't remember ever sleeping under a net, even when I was the chief distributor of nets at some point. I must be honest with you. I must be honest with you. Yeah, because I don't see mosquitoes where I stay, so I don't know, how this works. But it is good we take a holistic look. If you are given a job, we used to hear that when we were in government, if you are given a job like this, as a freeborn, go with your best intention, do a situation analysis, understand the problem properly, make a plan with the intention of solving the problem, not scratching the back of the problem or making a make-believe kind of system. Something happened recently. When they increased fuel price and liberalized the Naira, the next thing that happened was that the petrol price went up. In fact, it went to almost 1.4 and so on. And then Dangote came in and the government was fighting him. Oh, yes, as of today, Dangote, I hear, is importing crude to Nigeria. Nigeria is exporting crude. And then Dangote is exporting finished product. Nigeria is importing finished products. I don't know whether you know what level of stupidity that is. For the purpose that you don't want your Naira to be strengthened, even if it means adding up some things to make your Naira stronger. Because most of the hyperinflation we are having and other issues around as a result of the weakened Naira. Nigeria was seen as an importing nation. And then it is government that is now moving the agenda to import. And one of the things government brought, countries are moving out of fossil fuel. They are moving to renewable energy, electric cars and so on. And the Nigerian government said people should CNG vehicles and start rocking their cars, having the explosion and so on. And recently I heard that maybe they did that with a carpet to allow people to come in, and then the CNG price has now come to what it should be. And people are now regretting, oh, if I knew, I wouldn't have gone for CNG vehicle, as the case may be. The question is, what brought up that technical idea that it is CNG that is the solution to the problem? And something else, if Nigeria wants to be innovative, why not we look for one aerodynamic or one thing that doesn't use anything? You understand? If we cannot do electric vehicles, You understand? We do something that solar charge, and people can, at least people that want to commute short distances, can commute, without having to spend money. You understand? So it's important to have a holistic view, before marshalling. So I am KQ on health management. We'll take through that route, through the various ways of making or solving problems, in our society, if you are in a position to do so. All right, once more, thank you for your time.
Thank you so much, Prof. Thank you so much. It was a very interesting lecture.
Thank you,
Thank
Prof.
you, Prof.
Thank you, sir. Good night.
Thank you, sir. Good night.
Thank you, sir. Good night.
Thank you, sir.
Thank you, sir.
Have a blessed weekend. Thank you, sir.
Thank you, sir.
Thank you, Prof. Good night.
Please, who is our course rep? Is it Ikenna?